We're going to talk about the development of hematopoietic stem cell transplant, or HSCT, for multiple sclerosis, also abbreviated as MS. And I'm the individual that pioneered it. It goes on worldwide now. So I'm going to, in 20 minutes, give you a 35-year overview of the development of this field. Anyway, MS, for those who don't know, is a demyelinating disease of the multiple sclerosis system with classically periventricular. So here's the ventricles. Periventricular demyelinating white matter disease and juxtacortical. Out here is juxtacortical. And patients always give a good description of what their disease is. And Ann Romney is the wife of Mitt Romney, a former U.S. presidential candidate. And she described MS as losing who you are, which I think is a good description. So we're going to talk about how that was developed and the results of that compared to the drugs. So the first 10 years to develop this field, I worked on hematopoietic stem cell transplant in murine models, mouse models of MS, specifically two of them, EAE, experimental allergic encephalitis, also called experimental autoimmune encephalomyelitis. And we caused that in animals by adoptively transferring T cells to a naive animal, and then TMEV. TMEV is Tyler's murine encephalitic virus, and that's a polio-like picornavirus that causes the disease. I worked in both. So let's briefly go over 10 years of work in that model system. So we obviously in mice, you can use autologous, that is syngeneic or pseudo-autologous mice for donors. And the HSCT worked in relapsing-remitting MS, that is relapsing-remitting EAE, not in progressive MS, that is not in progressive EAE. The question is, would that model hold up in human MS? And it absolutely did. EAE is an animal model that mimics MS. It is a T cell mediated disease. So in other words, the way we cause the disease in a mouse is we immunize them with a little peptide of myelin. In the old days, you could use the whole myelin fragment. Now you use 12 amino acid peptide sequence, proteolipid protein or myelin basic protein, whatever, PLP, a common one, sequence 138 to 151 PL amino acids in that proteolipid protein chain that's in myelin. And you just immunize them with that. But the key is if you just give them that, immunize them, inject that peptide in them, absolutely nothing happens. You have to inject it with an adjuvant. An adjuvant is something that stimulates the immune system. And that adjuvant can be measles, mumps, rubella, tetanus, complete Freud's adjuvant, which is an oil with mycobacterium in it. Basically, as an adjuvant is something that turns on your innate immune system. Your innate immune system is not specific. It will attack anything out there that it recognizes as foreign. And then that turns on T cells, which are adaptive or specific to attack one particular target. But when there's the presence of this stimulation of the innate immune system, as well as an excess of myelin peptides, it instructs the adaptive immune system, your innate, your macrophages, dendritic cells, which are innate, instruct your T cells, a different adaptive type of immune system, to specifically attack myelin. And then it attacks the myelin in the brain and gives a mouse model of MS. Well, once the animal has that, if we take the T cells from that animal, from the spleen, and transfer them to a naive, healthy mouse, it'll get EAE or MS. If we transfer B cells, it doesn't. We focused on the T cell. And in the large history of the development of drugs for MS, they were mostly targeting T cells until recently. And I'll come back to that, why that's important. So we also learned, or I learned in the animal model, that the severity of the disease in the mouse correlated with delayed type hypersensitivity, or DTH, which is the ability of the T cell to traffic into tissue. It didn't correlate the proliferative response of the T cell to the myelin epitope, which you think it would, but it does not. It's the ability to get into the tissue that correlated with how severe the disease was. And so what I learned from that is autoimmune cells are normal, but autoimmune disease is pathogenic. And that's clear because when your pre-T cells leave the bone marrow compartment and enter the thymus for education, if they do not recognize self with very high avidity, they die. If they recognize self with moderately high avidity, they become Treg cells that downregulate immune response. If they do it with weaker avidity, they become autoreactive effector T cells that can target that organ. Specifically, we even took human T cells and exposed them to myelin peptides, and they proliferated like crazy. They are there. The T cell receptors for myelin are there, and they can become activated like crazy. But the people we did it on never had MS, and that's because they couldn't traffic to the CNS. So autoimmune cells or normal autoimmune disease is pathogenic. And that's very important to note because oncologists, I came out of the field of oncology that developed stem cell transplant for autoimmune diseases, tend to view autoimmune cells as pathogenic, just like they do a cancer cell. If you got a bad cancer cell, you got to get rid of all of them so it doesn't regrow and cause cancer. You just don't want any cancer cells. But you can never get rid of autoimmune cells. They return. It's the interaction between these cells, the balance, that is important in preventing autoimmune disease. We also learned that sustained fever exacerbates delayed neuronal injury. And that's important when it comes to clinically caring for patients when they go through transplant. So these animal models, that 10 years of experience, really laid a good foundation for the right group of people and some of the things you need to be aware of when you treat them. That is the right group of people with MS. So our first human protocol was myeloablative. We used a total body radiation-based leukemia regimen for secondary progressive MS. And I just told you in the animal model, it doesn't work in secondary progressive MS. So why would we do such a thing? And we reported those results in Blood in 2003. And so the question is, why did we do that? That's because nobody had ever done it in our NIH advisory board, despite the animal models that we'd published, mandated we start in secondary progressive MS, not relapsing remitting, because there was a fear perhaps there was a hidden virus causing this that would become activated and be a disaster. And that's true when in our animal model of TMEV, and we've reported that, that type of thing can happen. But the long and short, these patients act like an immune or autoimmune model and not a virus-induced demyelinating disease. But the NIH advisory board, nobody did start there in terms of risk benefits, so we did. And why use TBI, which is very myeloablative total body radiation? It's because we want to get good penetration into the central nervous system. There's always a question if a drug could cross the blood-brain barrier. Obviously, in areas of inflammation, it could. In other areas, the question remains. So we just wanted to get good penetration. So we used that regimen. And what was the outcome? It failed. So we reported in Blood in the title. I put failure in the title, as you can see in red there. Hematopoietic stem cell transplant for progressive. It was progressive, secondary progressive multiple sclerosis. Failure of total body radiation-based conditioning regimen to prevent disease progressions in patients with high disability score. That's very important in that TBI did cause one late case of myelodysplastic syndrome, which TBI is known to do. So in the top right there, I show you the rate of decline in the EDSS, and most of our patients, all of them, their EDS was higher than 6. EDSS is neurologic disability, 0 is normal, 10 is dead based on neurodysfunction. So the higher the number, the worse it is. And this is the further decline or increase in the points of the EDSS. They just continued to decline despite this treatment, showing that the disease was no longer immune-mediated. It was neurodegenerative. Whereas one patient at the end, we were able to enroll one patient that really was relapsing remitting, but later stages. And that patient, EDS was less than 6 and stabilized. So that told us we had to move this into relapsing remitting. And of course, we needed a safer regimen in terms of risk benefit, a non-cancer regimen if we were going to do that. And that's what happened. Our second and third generation protocols were safer, non-myeloablative, non-cancer regimens for relapsing remitting MS. And that's very important because there's a large group in America that's using a cancer myeloablative regimen to this day. So our second protocol used Cytoxan alemtuzumab, also known as Lemtrada or Campath. So in Cytoxan cyclophosphamide, that's non-myeloablative. We don't have to give the stem cells back. They'll recover just fine. We give them back because it shortens the period of neutropenia about 4 days, and the shorter the neutropenia, the better, the safer, the less transfusions, less infections, the quicker you're out of the hospital. And it was very effective in improving disability, which no DMT does. No DMT reverses disability. This did. But we had a high incidence of ITP, idiopathic thrombocytic purpura, 14% within the first 2 years. And that was due to the alemtuzumab because we were using alemtuzumab, and although it was FDA approved, after we started using it, got pulled off the market because neurologists using alemtuzumab, patients got ITP and some had died. So then they put it back on the market with the caveat that every month you have to check the platelet counts. But that bothered me. I just didn't want to use it anymore, despite it being very effective. We reported the results in Lancet 2009. So we went to our third generation protocol, which was Cytoxan and ATG. And that was effective in reversing disability with a very low incidence of ITP. We didn't totally eliminate it, but a low incidence of 1 to 3%. And we put that in JAMA in 2015. Again, I was first author. So I felt that, I was 145 patients. That was a great phase 2 study. It gave us a lot of good data what to do for a randomized trial. Remember, all DMTs never improved disability. This did in inflammatory. That's the key, inflammatory MS. So we decided now we can go forward with a randomized trial. But the question was, what's the post-Cytoxan alemtuzumab, and to a much lesser extent, Cytoxan ATG ITP, or secondary autoimmune disease, idiopathic thrombocytopenia purpura. And we looked at the immune system in these patients before and after transplant. And what happens is there's a very, very rapid recovery of immature B cells, but a slow recovery of your T cells, your CD4 positive Tregs. And without that, with that delayed recovery of the T cell, I think that's why some of these immature B cells resulted in a secondary autoimmune disease, ITP. And that is worse, much worse than ATG. So we kind of understood how that arose and what regimen to go forward for a randomized trial. So we started a randomized trial, missed multiple sclerosis international transplant trial. And to avoid the bias that can arise from one center, we did it in 4. Of course, the main center was here in America with me, and I was the PI, but we also did it in a university in Uppsala, Sweden. It's right next to Stockholm. In Sheffield in the UK, and the University of Sao Paulo in Ribeirão Preto, Brazil, but they only enrolled just a few patients. But the results from all centers were really the same, which is, of course, always encouraging when you do a randomized trial. So we called it MIST, Multiple Sclerosis International Stem Cell Transplant Trial. And we took relapsing remitting MS with 2 relapses in the prior year, despite DMTs. And so this was very inflammatory, active, immune-mediated MS. And our regimen was Cytoxan, total dose 200 milligrams per kilogram, ATG, total dose 6 milligrams per kilogram. It's not just the drugs, it's the dose. If you get a higher dose up there, if you get over 6.5, you can get late Epstein-Barr viral disease and PTLD, progressive post-transplant lymphoproliferative disease, as has happened in some centers. So the dose is important. When you use ATG at 6, that never happens. And as our control on this, we use the best available DMT. And the most common controls at that time was natalizumab or Tysabri, which is considered a highly effective DMT. So these DMTs or drugs are mildly effective, like Copaxone or interferon, moderately effective, and then highly effective group like Tysabri, Ocrevus, things like that, that are considered the best DMTs out there. So we compared transplant to the best available. Now, some people had already been on Tysabri, so it's whatever the neurologist thought would be the best available, and the neurologist could match and change if they had toxicity to whatever drug they were on, they could change it. So we did that. Now, what is unique about the control we used, which was the best available DMT? What is unique is that had never been done in an MS trial. Well, all drug trials, all DMA trials used a placebo against their drug, or they used the weakest DMT, the minimally effective DMTs, Copaxone and interferon, as the control. Why would they do that? A drug company wants their drug approved. If they compared highly effective DMT against another highly effective DMT, it may not be better, it may not get approved. So this way they got approval. Now that approval does give neurologists a broader range of drugs to use in case there's a toxicity to one, they could switch to another. But the point is their controls were against the weakest thing out there. And for the approval of Copaxone and interferon, it was against a placebo, a sugar pill. We didn't do that. We took the best available and did the trial, yet it was remarkably effective. So I want to show you how effective it was. If we look at the literature, we reverse neurologic disability, which no real drug does. So if you look at the reversal of the EDSS at 1 year, 2 years, 3 years, 4 years, 5 years, remember, transplant is a one-time treatment. You are done, no more drugs, unlike drugs that you keep getting treatment with. But you can see we had a marked improvement. This is the decrease in the EDS, which is a clinical improvement. Again, that scale goes from 0 to 10. If you looked at the best drugs out there, like Tysabri that we actually compared to, and these are from all Tysabri trials, or Lemtrada or Campath, which is a highly effective DMT, they very rarely report beyond 2 years. And as you can see, these had an improvement under 0.2, whereas ours is like 1.8. 0.2 is, to an individual patient, clinically meaningless. And the reason that is because the EDS scale changes at 0.5 increments. So one person can never or a neurologist can never pick up a 0.2 change. It's the lowest change you can detect is 0.5. So this number rises statistically when you have a large number of patients and you put them together and you look at the mean change. It's positive, but at a meaningless amount for a patient, whereas ours is highly meaningful. That's the major difference. And now all the other drugs, the moderately effective, minimally effective, they do not at all improve the EDSS, declining. And the highly effective ones here, Tysabri, Campath, Lemtrada, alemtuzumab, it's also called, they're improve it so slightly a patient can't detect the difference. In a large group of patients using the mean, you can show some things clinically relatively meaningless for an individual patient. Ours were phenomenal changes. And we reported out to 5 years. Drug companies often stop at 2 years. So what about NEDA, which is no relapse, no progression, that is permanent neurologic progression of disability. No relapse means you're not having an acute attack. And no new MRI activity means no new demyelinating lesions or enlargement of old lesions. And we compared our HSCT to drugs, and you can see we go out to 5 years. You can see NEDA is extremely high, 80 to 90% all the time. The drugs, again, here's a bunch of drugs, natalizumab, ocrelizumab, natalizumab's Tysabri, ocrelizumab, Ocreva, cladribine, alemtuzumab, Campath, Lemtrada, fingolimide, a whole bunch of drugs out here. And you can see drug companies just report to 2 years and stop. And they're about 30 to 40%, no evidence of disease activity at 2 years. We're at 90%, and we show our data going out to 5 years. The only study that's ever looked at 5 years was out of Harvard, where they called it the CLIMB study, and they just looked at all their MS patients at what happened for no evidence disease after 5 years of treatment, where the neurologist just gave the best DMT he thought he could give, and he could change it to clonic toxicity, or if it didn't work, he didn't feel it was working, he could change it to a different one. And they showed at 5 years, 13% no evidence of disease activity compared to our 80% and 30 to 40% for all these drugs, but nobody knows what they are out at 5 years. So it was a major difference. And if we look at quality of life, now the funny thing about all these DMTs is they do not improve quality of life. In fact, the drug companies don't even report quality of life in their primary trial when they publish it. They may or may not do another paper with quality of life. And a few drug companies have done other papers with quality of life, Tysabri, Ocrevus, Lemtrada, or Campath. Ocrevus is an anti-B cell drug. They reported again out to 2 years. Here's the Lemtrada report quality of life out to 5 years. These are our quality of life from transplant. Look at the difference. Now, the mild to moderately effectives do not improve quality of life. Neurologists will say the highly effectives like Tysabri, Ocrevus, or Campath or Lemtrada improve quality of life, and they can show the paper, and that's true, but that's misleading because the improvement of quality of life is like 2. Nobody's above 2. And this is the SF-36 scale, and SF-36 scale is a very validated quality of life scale used for many diseases. It has a very long history of being used, and it's very well documented that for a individual patient to feel that they have an improvement in their quality of life, that scale must improve by at least 5. So these numbers are statistically for a paper on a mean meaningful, but for an individual patient, they have no meaning at all because they're not above 5. A patient must have improvement of quality of life by at least 5. So it depends how you interpret the data. If you're looking at a statistical average on a paper for significance that has no meaning to a patient, 0 meaning, it improves quality of life. If you're talking about the patient having an improvement in their actual quality of life, because even the most highly active drugs are like 2, which is under 5, which is the minimum number for a patient to appreciate quality of life, transplant does it. The drugs don't. And the SF-36 is divided by physical, mental, and total. And you can see we report all of it. When I looked at the drugs, Tysabri reported only physical and mental, not total. I don't know why. Maybe total didn't show the number to be better, even though it's a clinically meaningless number. Ocrevus showed physical, not mental or total, and Campath just showed physical and mental, not total. Again, I don't know why they don't do that. Because once you do the SF-36, you can get that data to show all of it. But their papers just don't, and they don't comment why. I can only assume maybe the number wasn't positive. Although, again, these drug numbers are clinically meaningless. So when you say it does improve quality of life, you have to put that caveat behind it, okay? compared to transplant, where it's highly clinically effective in improving quality of life. Just think, a one-time treatment and your neurologic disability gets better. Quality of life improves. Plus, I've often found patients get off other drugs like antidepressants that they're put on and stuff. They're depressed because of the MS and they're only getting worse. Once they see they're better and they're off all drugs, they don't need antidepressants, for instance. All right, so are we consistent? Now, our randomized trial was in 4 centers. Yeah, there was no difference between the centers, and they were international centers. So are we consistent with the literature out there? So if different people report different things, but if we look at NEDA, no MS disease activity at 2 years, for multiple studies, HSC versus drugs. Again, here's all the drugs that we have reported, and you can see it's under 30% to 40%. Whereas you look at transplant, and these are non-randomized, they're out here over 80%, double the drugs. When we looked at our trial, now we have to remember we selected for highly active, highly inflammatory in the randomized trial. We were out to over 90% in terms of NEDA, and ours was at 3 years, not 2. But the DMT arm at 3 years was about 45%, which if you go down here, because we were comparing to the best highly effective ones like natalizumab, we were consistent with the literature. We actually did a little better. Natalizumab reports less than 40%, and we reported about 45% for the natalizumab arm. But as you can see, our randomized data is highly consistent with non-randomized. Now, a lot of these may not have I know they don't, I've read them as inflammatory MS. Key is the more inflammatory, the more immune-mediated, the better this treatment works. But it works. And randomized trials have been done, which we completed and published in JAMA in 2019. So what about cost effectiveness? We published a paper on this. We looked at the actual data. HSCT is $100,000 if insurance doesn't pay. And it's unfortunate for a patient to have to pay that. And we appeal and fight for the patient. We do all that for free. And if they don't approve it, we usually win on appeal, but not always. So that's the cost. And so that's for our regimen, non-myeloablative. Now, the cancer myeloablative regimen that some people use for MS is much more expensive. We're talking a lot more expensive. So you got to know the details here. But what's the cost compared to drugs? Well, if you look at when the drug was released, like interferon in 1993, it was $19,000. Another type, well, it's interferon, but it was a different company making it $13,000. Copaxone, which is Vladimir acetate, $12,000. Natalizumab, $31,000. All these drugs start out at a lower price, if you look at them in 2020, I haven't updated that data, but if you look at it in 2020, they've jumped from 19,000 to over 100, from 13,000 to 91,000. All the drugs are about $100,000 in 1 year, which is the price of a transplant, but you keep giving the drugs. Whereas transplant, the vast majority don't need any more drugs for a very long period of time. We showed the data out to 5 years. So it's a cost savings for the insurance company, as well as you get much better data in terms of improving neurologic disability and quality of life for the patient. You think it'd be a no-brainer. You think people would be all over it. And I want to show you this. Ocrelizumab. It's one of the most common, highly effective DMTs used. It's about a few-hour infusion in an outpatient clinic. 2017 came out at $68,000. 2020, it was the same price for a year. It is now $60,000 an infusion as of 2026. And the way they give it is they give one infusion, 2 weeks later, another infusion. That's $120,000. 6 months later, another $180,000. 6 months later, so at the end of 1 year, you're talking $240,000. This one, if I update it, 2026, $240,000. The price of transplant still $100,000 in 1 year. Yet insurance companies approve ocrelizumab all the time, and neurologists give it because it's in the pharmaceutical pipe stream. HSCT, there's no drug company involved. So I ask you, why do drugs increase in price each year at 5 to 10 times above annual inflation rate? But transplant, HSCT, using your own stem cells, your immune stem cells, has not changed in price for 20 years. How can that be? Well, the reason is drugs, DMTs, have a patent, a license, and a monopoly. That's why. So each new drug comes out at a certain level, and then as other drugs come out, they just increase their price to match the new drug. That's what happens. Whereas HSCT, we have no monopoly. We don't want a monopoly. We can't have a monopoly. There's no drug company involved. And the reason we can't is it's your own stem cells. You own them. There's no monopoly. Now, the drugs we use, Cytoxan ATG, their patents are long ago expired, so it's generic, so they're much cheaper. So for instance, in this list, this glatiramer acetate Copaxone recently lost its patent. Its price dropped from $86,000 in 2020 to about $38,000 a year now, which really jumps it back just a little bit above where it went to market in 2006. So it's really reflecting the true cost of production and selling it once the patent is lost. Now, drug companies say we need that patent to recover all the expense in developing it and so forth, but that's what happens. I developed this from animal models, phase 1, phase 2, phase 3, the randomized trial, over 35 years, just for the benefit of humanity. There's no patent, there's no royalty, there's no license. It's markedly cost effective. And I speak all over the world about it, but it's just my voice against thousands of doctors paid by drug companies with all new drugs coming out, giving talks at all the conventions and everything. So although I've spoken a lot, it's just one voice against so many. And there's also a financial incentive to give it, because if there's a $60,000 charge, it's shared with the hospital or the institution that you're in and the doctor, as well as the drug company. So it doesn't make financial sense. Not that anybody ever wakes up and say they wouldn't do anything that's right for the patient, but that's the problem. Doctors are trained to look at the mental health and physical health of their patient, but not the financial health. And if there's no financial health, there's no mental or physical health. And in fact, if you look at the data, as I have showed you, where you really get the improvement of quality of life and reversal of disability, and so improvement of mental and financial health, is with transplant. Neurologists don't know how to do it because it's an inpatient 2-week admission compared to an outpatient infusion. So there's a new problem that's occurred in the field of transplant for MS, and that is a lot of people are using anti-CD20 or B cell. That's an antibody to B cell antibodies like Ocrevus, also called ocrelizumab for monoclonal antibody. And remember what I said is that when we worked in animal models, we could transfer to EAE, the model for MS, that the results of which predicted our results when we treated patients with MS. We could adoptively transfer disease by transferring T cells from an animal with EAE or MS. We couldn't do it by transferring the B cell. In the early days, almost all these DMTs were directed against T cells. So there's a problem that has arisen, and I want to show you this. So what is going on in PIRA? That problem is called progression independent of relapse activity. So in other words, the patient comes in, they put them on Ocrevus, the neurologists do, and the patient doesn't have any more acute relapses. They still have ongoing symptoms, sometimes even worse, chronic, but the numbness, the weakness, the clouded consciousness, the problems with memory and recall and word finding, but they're not having that acute attack. And when they do the MRIs, they don't show any new lesions. But when you wait 5 to 10 years, the patient, after all those very expensive ocrelizumab, 5, 8, 10 years later, has progressed into a neurodegenerative disease and are now using a cane or a walker in a wheelchair. And that's called progression independent relapse activity because they weren't seeing relapses or new MRI lesions. It's most common in ocrelizumab. You can see it a little bit on some others. Also, Kesimpta, that's an anti-B cell drug. So the anti-B cells, which are very commonly used and generate a lot of money. So can inflammatory activity still be documented in PIRA? And we think it can be, because almost all MRIs, when they get an MRI, is 1.8 is Tesla. And the reason for that, those MRI machines, those magnetic field strengths are cheaper, so everybody does it. You run them through. They're very busy running MRIs all day long. And so you move your patients in and out, and the machines are cheaper. But the problem is they don't show you evidence of PIRA. You need a 3 Tesla or 7 Tesla. 7 Tesla is the best, and the FDA has approved 7 Tesla for imaging of MS or central nervous system disease. 3 Tesla works, though. It definitely does. And what it'll show, not only do you have to use the 3 or 7 Tesla, which many centers don't have because it's a more expensive machine, but you have to look for susceptibility weighted imaging. You have to tell them those are the sequences you want. And you look for paramagnetic rim lesions. And this is a patient, you see this little dark, almost curve here, half moon crescent, that's a paramagnetic rim lesion. And that's MRI evidence of ongoing, slow burning inflammation, despite the fact that this whole lesion never really changed. These other lesions didn't change, and there's no new lesions, and they would call it no PIRA, no evidence of relapse activity. Just keep treating with Ocrevus. So where do you find PIRA? Usually with anti-B cell therapy. Again, that's where you find it. And the problem is that the Ocrevus treats B cells. It decreases their number. It's an antibody to CD20 and B cells. It doesn't touch the T cell, which we use in animal models to adoptively transfer the disease. So the slow burn of the T cell continues. B cells also are good antigen presenting cells. So if you get rid of them, you get rid of the high flames of a campfire that show new lesions or enlarging lesions or inflammation. But the burning embers of the campfire are still there. That's the slow T cell burn that slowly destroys those neurons. And then you end up with progressive disease, neurodegeneration that nobody can help. And does PIRA with paramagnetic limb lesions still respond in transplant? Yes, we haven't published that, but because I've been getting so many people who are on Ocrevus and they're doing bad, but they just keep getting it because the MRI shows no new lesions, not an acute attack. It's a high five everywhere for the system, but the patient's getting worse. And I thought, okay, they're secondary progressive. I'm sorry, I can't help you. I won't do secondary progressive. My animal models told me it doesn't work there. The clinical trials at phase 1 we first did said it won't work there. But then I started thinking about this, and I read a paper on MRIs out of Europe where they made the drug company go back and they reevaluated the MRIs and documented that there was some PIRA on those few MRIs that had 3 or 7 Tesla, mostly 3 Tesla MRIs. So we started doing 3 Tesla MRIs when we see PIRA do it, and they get better, not as much as when they're really inflammatory. So if they didn't get Ocrevus, came to us up front, they would do phenomenally well. That's been our experience. That's our publications. They're stuck on Ocrevus 5 years, but if we look for this PIRA and also the clinical presentation that they're still complaining of these inflammatory symptoms like just complete mental fog and the numbness is still coming and going, they will respond. Not as well, but they still do. So PIRA is a problem for interpreting DMT studies. And I think people are being misled because they just look at the MRI without doing the proper type of MRI or listening to their patient. More important than the MRI is your patient. Is the patient doing better? Are they complaining? And the other where it could be a problem is in a randomized HSCT trial, because now everybody in a randomized trial is ongoing in Europe will compare to Ocrevus. Well, you're going to have to do the 3 or 7 Tesla MRIs, which they are doing. It's also a problem for CAR T studies, where they're directing the chimeric antigen receptor T cells against B cells. That's what they're directed against, B cells. They just think, why do that? That's $500,000 per patient, $500,000. Why do it when Ocrevus is $60,000 infusion, but every 6 months you're still getting it? And you can see the results from Ocrevus. I'm just talking about the problem of PIRA. They're doing because they think, well, their B cells decrease a lot. Maybe they're getting a lot of sinus infections, upper respiratory tract infections, and UTIs, so they don't have B cells, but it's working. And maybe there's still so few B cells in the lesions that the Ocrevus doesn't get, so we'll use CAR T cells and we'll really wipe it out. Well, nobody knows the results till it's done. But since they're not directed at B cells, it may just be a very expensive thing that the results will end up the same, but nobody's going to know it for 5 to 10 years. So I don't know. HSCT works really well. So current HSCT regimen and candidates, the regimen I use, Cytoxan, 50 milligrams per kilogram. This is 200 milligrams per kilogram. 50 milligrams per kilogram a day for 4 days. The first day 0.5, the second day 1.0, and then 1.5 for 3 days. We dose escalate to minimize fever, give steroids to avoid fever, and IVIG on day 8. They usually engraft on day 9, between 8 and 10, and are discharged. So the reason we give the IVIG is once COVID hit, all elective transplant had to stop. And then I was concerned that after discharge, patient get COVID, and I wanted to give them some immunity, passive immunity, because most of us have had COVID, and IVIG has pulled immunoglobulins for many people and will provide passive immunity for COVID. And in fact, after transplant, I've had patient get COVID. They flew right through it, no problems. They didn't take any drugs. They did great. And it also, by the way, is an important side effect, increased Tregs that may prevent that 1% incidence of late ITP. We don't know. I haven't seen it yet, but I don't want to brag about it because we just got to see what time brings. And Tregs be good to help prevent relapse as well. So that's the only thing we've added compared to the initial randomized trial. IVIG, by the way, is a drug used for really inflammatory MS, and it works. And it's not immune suppressive. It has antibodies that block infections, viruses, and bacteria. And not only is it not immune suppression, it increases Tregs to cut off immunity. Okay, so our candidates, it's all based on no inflammation, no response. So you got to get inflammatory disease. So newly diagnosed relapsing remitting MS diagnosed with enough lesion burden for a neurologist to start a highly effective DMT like Ocrevus. Rather than doing that, they should get a transplant. It's so much better. But yet, because there's an overwhelming number of neurologists out there that go to all the neuro meetings where all these DMT data is presented, and because of the financial for the institution, and because neurologists, doctors, all doctors don't think about the impact on their patient because insurance pays or someone else pays. So they just go down the system. But the patient would do better to at least be informed, be offered, let it be the patient's decision about HSCT up front. Non-myeloablative is definitely safer. It's not without risks, but the patient should be informed. Relapsing meaning that failed one DMT, the failure meaning a new lesion or inflammation, new acute attack, or active secondary progressive. So we won't do secondary progressive, but there's two types. Active means within the last year they've had a new lesion, an MRI or an enhancing lesion. Non-active means within the last year they haven't. I won't do non-active. We can still help active secondary progressive, but not nearly as much. We're getting to them almost too late to treat them, but we're right there where we can still help them a little. And then also we would do PIRA with radiologic paramagnetic rim lesions, which is usually from Ocrevus or other anti-CD20 antibodies. And we're seeing improvement in those patients, although we haven't reported that because that's a whole new thing where because of Ocrevus being used so much in America and Europe, we're now getting these patients frustrated that they're still having these symptoms or very slightly worse symptoms, and they just keep getting the same therapy. All right, so where's the future? My last slide. Hopefully we'll get it submitted to the FDA this year. And the future for me is induced pluripotent stem cells. And we have 7 patents on that. We started a little biotech company. We don't have a product yet. It's called Genony and Engineering Regeneration. What's an iPS cell? That's where you take an adult cell and genetically reprogram it back to the embryonic state. Then we make a few other changes so it'll only live for about a week because you don't want them hanging around too long. They can cause bad things. And during that time, they're quite capable of repairing virtually every organ we've looked at in our animal models. So where do we want to go? Our first trial will be for ALS because nothing really works in ALS because there's over 30 different genes involved are known, each one of which can cause ALS. But yet the majority, 85% of people, they don't know what gene is causing it. But the survival is variable, but the mean after diagnosis is 1.5 to 2.5 years, of which about the last 6 to 8 months, you have a feeding tube and a tracheostomy. So it's a horrible disease. With nothing really works. There's a few FDA-approved drugs that just kind of slow it a little bit, don't really work. So it's an orphan indication for a lethal disease. We have 2 sites lined up for the phase 1, University of California, San Diego, and University of Washington. We have great data safety monitor. Pamela Shaw, the UK, she runs all the ALS studies in the UK. And we're working to get that submission to the FDA. And if it works, if we're seeing that it works in our phase 1, hopefully, we don't know. If it doesn't work, it doesn't work. But if we actually see improvement in neurologic function, nothing does that. That's going to make us go right to a phase 2 trial, randomize phase 3, but where the control arm can cross over to treatment because it's such a horrible disease. But also, if we're seeing that it's working in ALS, that opens the door to treat progressive MS, where right now, all these patients and all these DMTs that end up with secondary progressive MS, I can't help. It's too late. Or they have PIRA and they end up with late neurodegenerative disease and I can't help. It's too late because they've been on Ocrevus for so long. I can't help them. If this iPS pluripotent stem cell therapy works in ALS, we will be doing it in progressive MS. That's it. A good thing to be aware of is this book, Everyday Miracles. I'm the author. You can get it on Amazon, Barnes & Noble, anywhere where you get books. And the foreword is by the Dalai Lama, His Holiness 14th Dalai Lama, which you can read right here. It's a kitchen soup for the soul. And it's going to tell you how this field was developed, but it's also patient stories. What was happening to them with these drugs and then what happened after transplant. And it gives you a history of how this was developed. It's easy to read. It's fun to read. And the patient stories are very moving. Here's a review from the president of Northwestern University and from a U.S. senator, as well as the Dalai Lama. Thank you.